Good afternoon, student. So, in the yesterday's lecture, we was discuss about the brief anatomy and the injuries around the elbow. Here, when we can see the diagram of the elbow joint, that is anatomy of elbow joint. So, you can see that is in extension position, that is posterior in the posterior view. This is a right elbow joint. This is humerus, olecranon fossa, the medial epicondyle and lateral epicondyle. And this is a groove for the ulnar nerve. And this is the ulna, this one is the radius. This is the head and neck and the tuberosity of the radius. And in the flexion position, the medial view shows this one is humerus, this is the medial condyle, medial epicondyle of humerus, capitulum, and this one is the trochlea. This is the radius, its head, neck, and the tuberosity, and this is the ulna. This is olecranon. This is the trochlear notch, and this one is the choroid process of the ulna. And then in the medial view, in the extension, you can see that this is humerus, radius, and ulna. So these are the secondary centers of the ossifications. That is, first one is a medial epicondyle, second is a trochlea, then third one that is olecranon, fourth that is lateral epicondyle, fifth is capitulum, and sixth is a radial hair. And this is a diagram of the relationship between the three bony points of the elbow in the flexion and extension, that is between the left lateral epicondyle and olecranon and the medial epicondyle. So this is also left epicondyle, medial epicondyle, and the olecranon. This is the carrying angle of the elbow. That this one, that is first one is a normal. Second is the increased carrying angle of elbow. It is called as the cubitus vulgus. And third, that is decreased carrying angle of the elbow is called as the cubitus varus. This is the supracondylar area in the children. That is, supracondylar fracture is commonly occur in this area in children. This is a supracondylar fractures mechanism that fall on outstretched hand is a common mechanism of the upper limb fracture in the children. So, when there is a supracondylar fracture, type of the supracondylar fracture is first is the extension type. So, when there is a extension, then it is 97.7% that it is commonly present, and in the flexion position, that is 2.3%. So, this is a extension type of the supracondylar fracture in which causing a neurovascular injury. Here is the nerves and vessels are also present. So, in the supracondylar fracture, in the extension position, there is a neurovascular injury. This X-ray shows the normal lateral view of the elbow. This is the radiograph that is X-ray, which showing the extension type of the supracondylar fractures, that is in antero-posterior view. This is a X-ray which shows the extension type of the supracondylar fractures here in a lateral view. So these are the signs that look the look for these important landmark on the lateral view of the elbow in X-ray, that is teardrop sign. Here, this is a teardrop sign. Teardrop sign is disturbed in a supracondylar fracture, but it is seen in the normal radiogram. Normally, there is an angulation of 40 degree between the long axis of humerus and the lateral axis of the long axis of the lateral epicondyle. So, it is seen in the normal radiograph, that is teardrop sign. Then B, that is anterior humeral line. This one is the anterior humeral line. Here is the from the long axis of the humerus. So it is called as the anterior humerus line. Then C, that coronoid line, that this one. And this is the relationship between the axis of the humerus and that of the lateral epicondyle. So, the quick facts are radiological point, the posterior displacement of the distal fragment indicated by loss of the teardrop sign, coronoid line and the fat pad sign and the anterior humeral line. So, coronal tilt of the distal fragment, which is usually varus, tilt rarely valgus, indicated on radiography by the crescent sign and the Bowman's angle. So horizontal rotation of the distal fragment is indicated by the fish tail sign. So this is a diagram that how the close reduction is done when there is a fracture of the humerus. So this is the technique of the close reduction of the supracondylar fracture of humerus. So this is the C, that is the final position for the close reduction. B, that is the correction. Here is the correction is done by the posterior tilt. And A, that is the longitudinal traction is given with the posterior and medial tilt. So management is conservative management. Firstly, initially close reduction is tried under the general anesthesia by the traction and the counter traction methods. That is given seen in this diagram. The medial and the lateral tilt is corrected first and the posterior displacement is the next. So an immediate check can be made whether the reduction has been successful by nothing the long axis of the forearm and the arm. It should be parallel. Remember that there is a long axis of the arm and forearm should be parallel. Any deviation from the normal indicate the residual uncorrected deformities. So 2 to 3 attempts under the same anesthesia can be made and the elbow is immobilized in hyperflexion. As in this position, the triceps act as an internal splint. So this is given in this, that you can see in this diagram that how the close reduction is done. In diagram A, B, and the forearm is pronated as in this position. The medial periosteal hinge closes the cortex laterally. Check the radiograph is taken and all the angles so far discussed should be restored. So it is restored to normalcy and failure of which is required considering the alternative method of the treatment like skeletal traction or open reduction and internal fixation. So there is a modified shoulder spica for 3 to 4 weeks has given good result in tractions method are it is indicated if conservative method fails. The traction method consists of skin or skeletal traction and is of historical importance. Of late, due to the availability of better and effective treatment methods. So surgery is include PCIF or the open reduction. Then there is a closed reduction and percutaneous fixation that is PCIF. In the cases where hyperflexion of the elbow cannot be done due to the gross swelling in and around, so this is technique of the closed reduction. So here is a management of the supracondylar fracture is given in a short. That is, supracondylar fracture is may be displaced or undisplaced. When it is undisplaced fracture, then POP slap for 3 weeks with the elbow in flexion. And sometimes there is a close reduction in stride firstly. So it is under GA. Longitudinal traction is given with the elbow in 10-degree flexion and forearm in supination. So medial and lateral displacement and rotation corrected first. Then there is a reduction of posterior displacement in done next. So distal management is finally secured to the proximal fragment by supinating the forearm and hyperflexion of the elbow. So take a check X-ray and check for the restoration of the radiological signs, both anteroposterior and lateral. So here, when there is a no swelling, then elbow immobilize in hyperflexion to neutralize the forces of the forearm muscles and enable the tricep to act as an internal spring. And when there is swelling is gross, then fracture is stabilized by medial and lateral percutaneous pins. So next is a when there is an undisplaced fracture, then traction is used in some conditions that Dunlop traction or overhead polychronon skeletal traction is used. Indications of these are compound fracture and comminuted fracture. Then, when there is a skin traction, then use a Dunlop traction, and skeletal traction, then use overhead polychron traction, that is the Smith traction. And when there is an open reduction, then indications are 4C. That is, open reduction require a closed reduction when there is a closed reduction is failed. When there is a compound fracture, complicated fracture, and a communicated fracture. So timing is should be within the 5 days of the injury. Then the advantages are there is a direct reduction, large hematoma can be evacuated, necessity in irreducible fracture, short hospital stay, or if is becoming increasingly popular. And it is particularly useful in the cases needing a fraction as it reduces the hospital stay. So advantage of these mixed fractions is it is easy to apply, provide a constant traction, provide a dependent drainage, and useful in the ipsilateral forearm fracture. And clinical infection is easy. And disadvantages are hospitalization cost is more. Then elbow is immobilized at least for 3 weeks. Pins or cast are removed after 3 weeks and active exercise are begun. So this is the diagram. That is A. It is a method of immobilization of supracondylar fracture of the humerus. And this is a B. A in the extension type and B in the flexion type. That is method of immobilization. Then this is the overhead olecranon traction, that is the Smith traction. That's how it is given here at this position of the olecranon. Then this is the tricep muscles. That when there is a fracture at the distal end of the humerus, tricep muscle act as an internal split in the supracondylar fracture of the humerus when flexed beyond the 90 degree. So the elbow and in grossly unstable fracture, percutaneous fixation of the fragment with the K wire on either side of the close reduction is an acceptable form of treatment and is widely accepted. So the open reduction is this is rarely indicated in a certain special indications as depicted in elbow chart. An open reduction is invariably followed by the internal fixation with plate and screw. For the treatment plan of the supracondylar fracture of the humerus, complications are these are broadly divided into the two categories. That is, those that cause a functional impairment of the extremities and the more severe, and those that produce the more cosmetic sequelae. So, complication causes of functional impairment include neurological involvement, that is, overall incidence is around 7%. Radial nerve, when there is the most commonly affected and is usually injured in the posteromedial displacement. Median nerve, that is injured during posterior displacement. Anterior interosseous nerve, that is the injury is seen in the posterolateral displacement of the distal fragment. Ulnar nerve, when it is injured in overhead skeletal fraction and in flexion type of the supracondylar fracture. Vascular injury, that is, the incidence is between 0.5 and 1% and common with the extension type and is usually due to the direct injury of the brachial artery by the fracture. So the other causes are internal thrombus, initial tear, brachial artery spasm, external compression of proximal fracture fragments of the rupture of the brachial artery. So you can see that in this radiograph that is showing a percutaneous fixation with the K wire of displaced supracondylar fracture of the humerus. So this is a diagram B. Here you can see the fracture of the supracondyl. This is a medial view, lateral view, and here is a K wire displacement. This is a K wire used for the displacement of the supracondylar fracture of the humerus. Then complication are loss of mobility, that is average loss of flexion is 4 degree and is usually due to the posterior displacement which unites in that position causing a mechanical block or flexion. And myositis ossificans, that it is rare and is seen in the manipulative close reduction and the open reduction. Then Complications that produce cosmetic abnormalities are: first is a Cubitus Varus, that is gun stock in. So this is the diagram of the Cubitus Varus deformity, also called as a gun stock deformity. It is like a gun stock. Cubitus Varus, that is gun stock info, is called so because the deformity resembles a rifle gun stock, and this is the most common complication of supracondylar fracture. Incidence is varies from 9 to 58%. The deformity become obvious in an extended elbow, and the following are three static deformities of the cubitus varus, all with respect to the distal fragment. There is the posterior displacement, horizontal rotation, and the coronal tilt. So in that, the causes of cubitus varus, that is a 4I, that is improper person splitting, then there is an improper reduction, improper interpretation of radiograph, and improper follow. So the 4I are very important causes in the cubitus varus. That is these four. Then Panthomechanics, that posterior displacement and horizontal rotation predisposes to coronal tilt. Because the edges of the fracture fragments are thin, there is very little resistance to coronal tilt. If the fragments are horizontally rotated and contraction of the biceps produce a medial tilting force. All these three components should be corrected during the initial reduction of the fracture. Otherwise, cubitus varus deformity results. Then, the determination of the quality of fracture reduction after the initial injury can be assessed by the following clinico-cardiological tests. So, clinical tests are: when there is a long axis of the forearm and humerus should be parallel when elbow is placed after reduction. And radiograph shows that AP view, that is Bowman's angle, should be less than 5 degrees. Lateral view, when all the normal radiological signs should be restored if the clinical co-radiological criteria are satisfactory. The close reduction is accepted, otherwise re-reduction is attempted. So ignoring these criteria after close reductions result in the future cubitus varus default. Then the treatment of cubitus varus is only a cosmetic disability with no functional impairment of the elbow. So treatment of choice is corrective osteotomy and is deferred until the skeletal maturity as cosmesis gains importance in this age and for the fear of recurrence of deformity. So if surgery is done before growth stops, since there is still potential for the growth late. Then osteotomy method is lateral close and wedge osteotomy, that is French and modified French. So this is a French osteotomy. That how there is a osteotomy done. That this operation is simple and easy to perform. The posterior tricep splitting approach is used. And in this method, osteotomy is done between the two screws. The first screw being placed anteriorly in the distal fragment and the second screw is being displaced posterior in the distal fragment. After the osteotomy, the distal fragment is rotated such that both of the screws become parallel to each other, indicating the correction of rotational deformity. A wedge of bone is removed from the lateral cortex, the gap is closed, and a figure of 8 stainless steel wire secure both the screws against each other, and this way the cubitus varus is corrected. So then next is a medial open wedge osteotomy, that is King's osteotomy. This is the opposite of lateral closed wedge osteotomy. In this, a wedge of bone is respected of the medial aspect of the deformity is corrected. Then derotation osteotomy. This technique is not as popular as lateral closed and the medial open wedge osteomyosis. So treatment fact of the cubitus varus is Cubitus Varus is a cosmetic problem and not functional. So before the skeletal maturity, there is observation is necessary. Then cosmetic consideration are not very important before attenuation. And if surgically corrected, deformity may recur. And after the skeletal maturity, there is no further growth is left, and hence the recurrence chances are nil. So deformity is full blown. Girls and boys are more cosmetically concerned at this age, and hence corrective osteotomy is performed. Then a cubitus valgus, that it is very rare and may be seen in the posterolateral displacement in the extension type of the supracondylar fractures. Unlike the cubitus varus, it is a cosmetically acceptable, and the treatment is by medial closed wedge osteotomy. Tardy ulnar nerve palsy is distinct possibility in the cubitus valgus deformity. So flexion type of the supracondylar fracture, that this is extremely rare and has an incidence of only 2.5%. Then this is a self-per technique of reduction. So mechanism of injury shows that the common method of injury is direct blow to the posterior aspect of the arm. Angulations seen in the lateral radiography are reverse of extension type, and this fracture is associated with the high incidence of ulnar nerve injury. And treatment is that close reduction and immobilization in the above elbow cast in extension is undesirable. So as it causes the elbow stiffness, overcome this, a Sultanpur technique is used. If reduction can be achieved by close method, the fracture can be stabilized in flexion with percutaneous pace, and if reduction cannot be achieved, then open reduction and internal fixation is contemplated. So this is the Sultanpur technique. Here, Sultanpur technique of the reduction. So this technique, which help to immobilize the flexion of supracondylar fractures in flexion, rather than the conventional extension. The two-stage casting. First cast is pulled until the distal end of the flexible fragment and is allowed to set. And next, the distal fragment is pushed back against this cast. The cast is then completed with the elbow in the flexion. The complications are injury to the ulnar nerve is common in this type of the fracture. The loss of elbow flexion is another important complication which is commonly encountered. Firstly, injury to the nerve and then loss of the elbow flexion. Then the quick facts are supracondylar fracture of the humerus is the second most common injury next to the forearm fractures in the chin. It is characteristics pathological anatomy and extension type account for 98%, and study and restoration of radiological anatomy is very vital. There is the closed reduction is difficult. Open reduction in specific indications and Cubitus Varus is the most common complication. Then dislocation of the elbow joint that it is rare in the children below the 10-year of age. Incidence is 3 to 6%. In the male it is 71%. Then non-dominant extremity that is 62%. 50% of all elbow dislocation occur in a patient which is less than 20 years of the age. Then mechanism of injury that this is frequently due to the fall on outstretched hand with the elbow slightly flexed. A valgus twist is added to the longitudinal force by the projecting trochlea and thus the dislocation is usually posterolateral. So commonly seen in sporting events and in artery, that is in road traffic accident. Classification by the Smithson, that is he described the elbow dislocation with respect to the position of radial ulnar unit to the distal humerus. So this is a terrible triad of the elbow, that is posterior dislocation of the elbow, radial head is fracture and the fracture of the coronary process of the ulna. So clinical feature consists of there is a severe pain, swelling, deformity, severe loss of movement of the elbow, and rarely there could be the features of neurovascular injury. So it is frequently confused with supracondylar fractures but can easily be differentiated. So this is the Smithson's classification. In that there is a proximal radioulnar joint is intact when posteriorly 90% that is posterior lateral and the posterior medial. Then anterior, medial and the lateral. And proximal radioulnar joint disrupted in the divergent dislocation. That is in A anteroposterior, that is radius is anterior and ulna is posterior. And the medial lateral, that is transverse, that is radius in the lateral and ulna is medial. Then comparative features between the AC fracture humerus and the posterior dislocation of the elbow. In that AC fracture humerus, that younger children, when the arm is short, bony triangles maintained, swelling is more, crepitus is present, olecranon is below intercondylar line, then step sign is negative, and the movements are rested. And the last is radial nerve commonly affected. Then the posterior dislocation shows that there is a in slightly oriented. Forearm is short, triangle is disrupted, then swelling is less, crepitus is absent, olecranon is above the intercondylar line, step sign is positive, and the movements are grossly restricted. So medial and ulnar nerve is injured. Then this is the interesting fact that associated fractures in the posterior dislocation of elbow shows that medial or lateral epicondyle fractures, that is in 18 to 34%, coronal process, that is in 5 to 10%, and the radial head fracture. So radiograph, that is show AP view, that is a greater superimposition of distal humerus, the proximal ulna and the olecranon is seen. And the lateral view, that is a coronal process lies posterior to the condyles of the humerus. So treatment in that conservative treatment by the close reduction under the general anesthesia is attempted first, and reduction by the postoperative method is reserved for those rare cases of failed close reduction. So, Smithson's principle of the close reduction, that according to the Smithson's, the effective method of overcoming the muscle forces are in that step 1, that is traction along the long axis of the humerus to overcome the contraction of the biceps, brachialis and triceps muscles. And in step 2, that is once these forces are neutralized, the second force along the long axis of the forearm is employed to pull the proximal radius and ulna back into the position. So this is the deformity from the side. That this is the clinical photo. This is the deformity from the front in the clinical. Then this is a radiograph which shows the posterior dislocation of the elbow joint, that is in AP and in lateral view. Then an above elbow POP slab is applied with 90% elbow flexion and mid pronation for a period of 3 weeks after the close reduction under GA. That is, here you can see the close reduction under GA, that which causes a deformity from the front and from the side. Clinical. This is a diagram of deformity from the closure view. Clinical. This is a radiograph, that is shows a lateral view. This is the deformity lateral close view. This is the method of the reduction, that is the traction with the elbow slightly flexed. And this is the radiograph in the lateral view. Here is the diagram of the traction and counter tractional, which is continued gently. This is the diagram where elbow is gently flexed here and reduction is successful. So this is a diagram of the immobilization in and above the elbow slab. So this is the elbow slab. This is the post reduction C arm picture. C arm is a machine which is used for the orthopedic operations. So here is the post reduction C arm picture, that is in anteroposterior view. This is a post reduction C arm picture in the lateral view. So this is the techniques of reduction, that is close reduction and open reduction. In the close reduction, there is a pusher's technique is used, and the method employed in the children, that is pushing force is applied to tip of the olecranon with the thumb. Moreover, with the patient lying prone, and this is useful in the younger children. And in open reductions, the indications are there is inability to obtain a close reduction, open dislocation, then puller's technique, that method employed in adults, pulling forces applied to the forearm with the elbow in 70 degree of the flexure. So this is useful in the older children and in the young adolescents. Then the complications are there is a neurological injuries. So in this, the ulnar nerve are very commonly injured, followed by radial and the medial nerve in that order. So there is a myositis ossificans. So this has an incidence of 5 to 18% and is generally not due to the injury per se, but due to the manner in which it is treated. Causes are there is a delay in initial treatment, use of the hyperextension force during reduction, vigorous active physiotherapy and massage are some of the common causes. Then arterial injuries, that they are rare, but brachial artery injury may be seen in the open fractures. So this is a method of the close reduction of the elbow joint by the pushers technique in the children. And this is in adult, that is puller technique. Then recurrent dislocation. So this is a relatively rare but can be seen in male and usually found to be confined due to the pediatric age group. So pathology is that there is a lax ulnar collateral ligament and pocket in the radial collateral ligament. The defect in the posterolateral aspect of the lateral condyle are the common pathological findings. So treatment is surgery is the treatment of the choice. Then there is a soft tissue procedures consist of tightening of the radial collateral ligament. And bony procedure shows here a graft is placed to deepen the semilunar notch of the ulna. Proximal radio-ulnar translation, that this is an extremely rare complication and is due to the very vigorous forces used during reduction method. Osteochondral fracture, that these are relatively uncommon. And unreducted dislocation, Unreduced dislocation, though rare, it is more often seen in Asians due to the ignorance and treatment by the vets. Then, unreduced dislocation of the elbow. So, clinical feature of it is the patient with unreduced posterior dislocation of elbow joint have fixed flexion deformity and gross restriction of elbow movement. There may be wasting of the arm and the forearm muscles. So, the treatment method is in the children, there is open reduction and resection of myositis is done in the child. And if it is less than 3 months duration, the open reduction alone is done. If the injury is greater than 3 months, then the open reduction is combined with arthroplasty if necessary. And in adult, the open reduction are invariably followed with one of the following arthroplasties. So the other important complication are there is a loss of the motion, which is about 10 to 15% loss of the extension. So this is the table of different types of the elbow arthroplasties. First one is the interpositional arthroplasty, that is facial, in that done in mobile joint with minimal pain. There is a tricep fascia is used. Then implant arthroplasty in that given a stable painless and mobile elbow and technically difficult and expensive. Then resection arthroplasty causes instability and is rarely used. 15% average loss of strength. Then there is a ectopic calcification seen in 75% of the cases and heterotropic calcification that is seen in the 5% of the cases. So next is the radial head fracture. Radial head fracture is a common injury in the adult and is rare in the children. So mechanism of injury is there is an indirect trauma due to the fall on an outstretched hand and direct trauma due to the RTA and assault etc. in the adult. So this is a diagram of the radial head fracture which is complete. This is the anteroposterior view. This is the lateral view. That is the radial head fracture. So Mason's classifications are type 1 when undisplaced fracture, type 2 when there is a marginal fractures with displacement, then type 3 that is comminuted fracture, type 4 that is the radial head fracture with the posterior dislocation of the elbow. Clinical features are the patient with the radial head fracture complain of pain on the lateral side of the elbow, minimal swelling and restriction of elbow movement and supination, pronation of the forearm, and there is a tenderness over the radial head and crepitus can be elicited. So this is a excision of the radial head here. Here you can see there is the excision of the radial head. Plain X-ray of the elbow including the anteroposterior and the lateral radiograph of the elbow and additional oblique radiograph delimited the fracture line better. So CT scan help to delimit the fracture pattern better. Then the method of the treatment for the different types of fractures of the head of the radius is that there is type 1 that is non-operative means aspiration of elbow within first 24 hours which decreases the pain. early mobilization within 24 hours. Then type 2, there is the excision of the head of the radius. So there is angulation is more than 30 degree. The pressure is more than 3 mm. Involvement of more than one third of the head. Then type 3, that is radial head excision is indicated within the first 24 hours. Then excised head is replaced with prosthesis. And type 4, that there is a prompt reduction of the dislocation is must. And there is a assess status of the head. If it meet the criteria for excision, do it within 24 hours. So this is a complication. Then complication is injury to the posterior interosseous nerve and osteoarthritis and the elbow stiffness is the common complication of the radial head fracture. So the radial head excision does not cause instability due to the presence of intraosseous membrane or the functional impairment due to the distal radioulnar tube. So this is about the fracture of the radius. So we can stop here, and in the next lecture we will continue our orthopedic with the fracture of the collarbone. So now we stop here.